Hi there, and welcome to our live stream. We're going to talk about breast cancer today. I'm going to give you a few facts about breast cancer. Breast cancer is the most common cancer in women, and it's the second most common cause of cancer-related death in women. There are roughly 288,000 new cases of breast cancer this year in the United States, and there are 43,500 deaths from breast cancer. About 1 in 8 women will develop breast cancer in their lifetime, and there are 3.8 million survivors living in the United States. Mortality has dropped significantly since 1950, mostly through early detection with screening mammograms and the judicious use of postoperative therapies, including hormonal or anti-estrogen therapies, and of course, chemotherapy. And now we have a new class of therapies called targeted therapies. So we're talking to you today on behalf of the Stony Brook Cancer Center and the Carol M. Baldwin Breast Care Center at Stony Brook University Hospital, as well as the Phillips Family Cancer Center at Stony Brook University. At Stony Brook Southampton Hospital. I'm Dr. Jules Cohen. I'm a medical oncologist specializing in breast cancer. Joining me is Dr. Alexander Stessin, a radiation oncologist at the Stony Brook Cancer Center. And joining me also is Dr. Edna Kapenhas, breast surgeon and medical director of the Ellen Hermanson Breast Center at Stony Brook, Southampton. We are going to jump right in with our discussion of breast cancer, but I do want to remind you that if you have any questions, you can comment below. Or if you would like to remain anonymous, use the QR code up on the screen it's up there right now. And you can submit your questions anonymously, and we will do our best. We can't promise, but we'll try to address all the questions that come in. We're going to start with Dr. Kapenhas. Can you please explain the benefits of early detection of breast cancer?
Hi, everyone. So early diagnosis and treatment of breast cancer are the two most important factors in reducing breast cancer-related deaths. So early detection means the cancer is picked up at a smaller size. That means earlier stage, and therefore it hasn't spread, and more likely to be treated successfully, more easily to be treated successfully. So getting regular screening mammography is the most reliable modality to detect breast cancer at early stage, and therefore early detection. So in average risk population, we start mammography at age 40. In patients who do have family history of breast cancer, we start screening mammography 10 years younger than the age of the first degree relative diagnosed with breast cancer. Of course, the latest to start would be at age 40. And in certain high-risk populations, we may actually start mammography at age 30. And we may add screening MRI as another tool in screening the patient. Unfortunately, with the pandemic, there was significant drop in cancer screening, so more advanced breast cancers were picked up at the time of diagnosis. So that's why it's extremely important not to put off your screening.
So, Dr. Kapenhas, a lot of women will be told that they have dense breasts on mammogram. How does breast density affect the mammogram and our ability to interpret it?
So what breast density means, it's the measure of fibroglandular tissue compared to fatty tissue within the breast. And it's not related to breast size or firmness of the breast. And nearly 50% of women who are 40 or older have this, who have mammography, have dense breast tissue on their mammograms. What happens is that the dense breast tissue actually makes it more challenging for any abnormalities to be seen on mammography. And in those cases, we also recommend additional studies like an ultrasound is important in setting of dense breast tissue. And 3D or three-dimensional mammography is particularly useful in setting of dense breast tissue.
I'd like to turn to Dr. Stessin. Dr. Stessin, can you walk us through what happens if you do have an abnormal mammogram?
Sure. So, the proportion of mammograms that have abnormalities that require biopsy is actually pretty small. It's something on the order of 12 per thousand. And these abnormalities could be calcifications, asymmetries, or architectural distortion, or sometimes masses. Some of these abnormalities don't need immediate attention, and what's recommended is close interval follow-up. So repeat the mammogram or sonogram at 6 months rather than in the normal year. And there's actually there's what's called a BI-RADS scale that communicates the index of suspicion that the radiologist has for a particular mammogram finding. Right, so a BI-RADS 2 is something that's essentially benign, BI-RADS 3 most likely benign, then once you get into BI-RADS 4, it kind of runs the gamut of something being a little bit more suspicious. And among the abnormalities that are biopsied, only half of these actually show cancer. When the biopsies are performed, it's usually done by the diagnostic radiologist rather than the breast surgeon. And there are several types of biopsies that can be done, including stereotactic biopsy, mammo-guided, or ultrasound-guided biopsy, or sometimes MRI-guided. And the biopsies are then sent to a pathologist who reviews to see whether there's cancer present. And there are several things that we want to know. If there is cancer, is it cancer that's in situ, what we sometimes refer to as stage 0, that hasn't broken through the basement membrane, or is it cancer that has now become invasive or infiltrative? What kind of breast cancer is it? There are a couple of different types. There's most commonly the ductal or the lobular breast cancer. What is the receptor status? Is this cancer that's estrogen and progesterone driven? Is it positive or negative for HER2? And once the biopsy results are back, if there is cancer there, then the next step is the patient being referred to a breast surgeon.
We have a couple of relevant questions here that I'll read for you, and then we'll do our best to try and answer them. Linda asks, will insurance cover screening mammograms at age 30? And similarly, we have an anonymous question that says, New York has a new law for insurance to cover baseline screening mammograms for women 35 to 40, but the guideline is to start at 40. Do you advise women ages 35 to 40 to get one? Dr. Kapenhas, do you feel like answering these questions, and then I can try to chime in?
Yeah, of course. So I would say I don't want to make a general statement across the board that everybody age 35 to 40 should get a mammogram. I would say that is different for each different patient. So certain population, as we discussed before at the beginning of the chat, I would get a mammogram at age 30. So it all depends on, the patient, their family history, whether they have any genetic mutations. So I would say that I would tailor it to the treatment of that particular patient.
Yeah, I mean, there are pluses and minuses to early detection, and especially at a very young age. There is this concern of overdiagnosis and finding, say, DCIS or in situ breast cancer when it's small and slow growing and may or may not cause a problem in the future. So the more you screen and the more you expose, women to radiation and to mammography and ultrasound and so on, potentially the more you find. But the question is that always good? So it's a complicated discussion. We probably can't get into the full scope of it here. But I think 40 is a reasonable compromise. But certainly, if you have a high risk because of your family history and so on, it's prudent to do it earlier. I'm going to bring up another question here. It's another anonymous one. They say, my husband's cousin was of Ashkenazi Jewish descent and died at age 36 from BRCA2 positive breast cancer. It is very important to stress that this type of risk factor could or should drastically alter screening recommendations. It's often I'm just trying to parse the language here. It often just gets lumped into vague phrases like, quote, discuss your risk factors with your doctor. But I don't think, quote unquote, risk factors are explained or stressed enough. Genetic screening can be very expensive. Are there ways to educate these populations and help people? And all right. So, Dr. Kapenhas, do you want to talk a little bit more about, high-risk patients, especially patients with known BRCA1 or BRCA2 mutations?
Yeah, so we actually have a section on genetic testing. I can just jump into it now rather than later. So genetic testing is actually another one of the major advancement in the field of breast cancer prevention treatment. And the two more well-known genes that we know about are BRCA1 and 2 mutations. Of course, there are many other ones that are not as well known as BRCA, but they're very important as well. Just to put everything in perspective, BRCA1 and 2 mutations, most patients who are diagnosed with breast cancer do not have any family members with history of breast cancer, and they do not have a genetic mutation. So just put things in perspective, only 1 in 200 people have a mutation in BRCA1 or 2. But in certain ethnic groups, like you just mentioned, our anonymous question that came through among Ashkenazi Jewish population, that number can be 1 in 40. And it's important to know the risk status of the patient, whether they are diagnosed with breast cancer, or they're not. In that case, it would be preventative for them. But I just want to put everything into perspective that we got to be selective. We can't, as of now, there are certain criteria that we follow to order genetic testing on patients, family history, or if they're diagnosed with breast cancer themselves, and various other things that we use. We can't just go ahead and, screen everybody across the board, general population, whether they have, any history or not. But I think that you're absolutely right. Whoever asked the question, that there's got to be more education and there's got to be more awareness that genetic testing needs to be used more widely. And in cases where it's indicated, it is definitely covered by insurance.
So yeah, and I mean there are a number of sort of classic breast cancer risk factors. Certainly if you have a strong family history, whether or not you know that there's a genetic mutation in the family, that in and of itself is a risk factor. And of course, other cancers such as ovarian cancer and other cancers may also be associated with an increased risk of breast cancer in the family.
And the other thing that I would mention also is, as I think as Dr. Kapenhas mentioned, there are a number of mutations that are potentially associated with breast cancer. So BRCA1, BRCA2 are the most well known. But nowadays, especially for Ashkenazi Jewish women, they would have a genetic screening panel, and that would show potential mutations in other genes like PALB2, CHEK2, etc. And the question is what to do with that information, right? So for some of the BRCA mutation patients, the recommendation would be to consider a double mastectomy, whereas for some of these other ones, the recommendation may be just to follow more closely. And I think that this component of the education is also very important, right? So let's say a patient does this genetic screening panel, they're found to harbor some kind of mutation, the discussion needs to be had regarding what that actually means for the patient, how much that increases the risk. Does it automatically mean that the patient should go and get a double mastectomy? In most cases, probably not.
I just want to add one more thing since we're on the topic of genetic testing. Again, to put things in perspective, the risk for general population for breast cancer is about 12%. In someone who has a BRCA mutation, it can be up to 85%, which is just significantly higher, 85%. Now, this risk, like Dr. Stessin just mentioned, in terms of in setting of BRCA mutation, it can be decreased by about 90 to 95% with prophylactic mastectomy. So that's something that definitely needs to be discussed with this population having this genetic mutation. But again, just like Dr. Stessin mentioned, the other genes, the risk is not as high, it's not as well known. So it's kind of, okay, do they have family history as well, which with the other genes, family history can increase even the risk even further. So it's a discussion and definitely needs to happen before a decision of that magnitude is made.
And I would say, of course, genetics is important, but it's not the only thing. So there are more traditional risk factors that we need to pay attention to and not forget about. And so sort of total lifetime estrogen exposure is considered a risk factor. Women who start their periods early or who continue to get their periods late and go through menopause late are at slightly increased risk. Certainly women who use hormone replacement therapy at menopause to control menopausal symptoms, they're at increased risk for breast cancer. Women who've either have never had a child or have their first child later, they're at increased risk. And one often unappreciated risk factor is dense breasts. Something like Dr. Kapenhas said, 40 to 50% of women are diagnosed with dense breasts, heterogeneously dense breasts, and so on. And states like New York have laws that mandate that women are informed of their breast density. And breast density, in addition to making mammograms harder to interpret, is also associated with an increased risk of breast cancer.
And the other thing that I would mention is, I think one of the common questions that all of us get asked is, so a patient comes in and says, listen, I don't have any family history, right? I'm not Ashkenazi Jewish. I breastfed, so how come I got breast cancer, right? And the answer is that, it's very important to be aware of these risk factors, but the truth is that there are a lot of patients who have no identifiable risk factors, right? And as Dr. Kapenhas says, it's a 12% lifetime risk for any woman. So the most important take-home message is that we've gotten a lot better at treating and curing breast cancer as long as it's detected early. So, doing the screening mammograms and doing the early detection is probably the best thing that can be done.
Dr. Kapenhas, can you tell us about the role of surgery in breast cancer and why it is often, but not always, the first step in treatment?
So, like you said, in majority of cases, surgery is the first step in breast cancer treatment. So the initial visit that the patient has with her breast surgeon after the diagnosis is actually a very important visit. That's the visit that, in addition to obviously doing the history and physical, the findings on imaging, the biopsy results, the staging of the tumor and characteristics of the tumor are reviewed with the patient. And then various surgical options are discussed, as well as what they can expect as far as recovery and any potential post-surgical treatment planning. So obviously surgery is important because you need to remove the gross disease, the gross cancer, before we go ahead and do any other treatments. The surgical options can vary anywhere from lumpectomy to mastectomy, plus minus lymph node assessment, depending on the case. And in certain cases, depending on the size of the tumor or the stage of the tumor, if the tumor is very advanced, or certain characteristics of the tumor, the patient may be referred for upfront chemotherapy. So upfront chemotherapy, or what we call neoadjuvant chemotherapy, can potentially shrink the cancer. It can potentially make a case that was not operable into a case that now is operable. Or it may turn a case that needed to be a mastectomy into a case that now can be a lumpectomy.
Very good. I'm just going to cover some comments now from Wasim Nawaz, a resident in medical oncology, I believe. The question is whether hair dyeing is a risk factor for breast cancer. And I would say, probably not. I mean, chemical exposures, are always a concern, whether or not they're carcinogenic. But, we basically tell patients that they can start dyeing their hair, say, after their chemotherapy when their hair is coming back, for those who do lose their hair, because not everyone loses their hair if they get chemotherapy, depending on which chemotherapy you get. But generally, we don't consider it a real risk factor for breast cancer. Lori writes, at what point would you be told you have dense breasts? That's an easy question. The very first time you ever get a mammogram. That is one of the features of the mammogram that the diagnostic radiologist will describe. And so you should know from that very first mammogram. You can generally, I think these days, because of the New York State laws, you can now, review your own mammogram report online through a patient portal, and they should tell you the density of the breast. Generally, there's a continuum from the least dense to the most dense. The least dense, we talk, it's unfortunately named predominantly fatty, and then sort of average density we call scattered fibroglandular elements, and then we get to sort of the denser breasts, which are considered heterogeneously dense, and then of course there are some people who have very dense breasts or extremely dense breasts and so on, and that should be on the mammogram report. And then if it actually says that there are dense breasts, I believe you get a letter from the radiology facility. Dr. Kapenhas, can you tell us a little bit about sentinel lymph node biopsies and operating on the axilla or the armpit, and how that has changed over the years in order to reduce side effects and toxicities from surgery?
So it's sort of the concept of less is more or less is better. So sentinel lymph node biopsy is a modern breast cancer surgical tool that allows us to remove fewer lymph nodes and therefore fewer potential side effects like lymphedema, and still gives us accurate information about the status of the tumor and whether it has spread or not. In certain cases, even when the sentinel lymph node is positive, nowadays with the new data, we don't always have to go ahead and completely remove all the lymph nodes, or what we call X-ray lymph node dissection. So that's another advancement in the field of breast cancer. So it's a sentinel lymph node biopsy is a less invasive way of assessing the lymph nodes in the setting of breast cancer.
At this point, I want to remind all the viewers that you can submit questions. We've gotten some really good questions so far, and you can either do it below on your device, or you can use the QR code up on the screen right now to submit your questions anonymously. We're going to turn to Dr. Stessin again. And Dr. Stessin, what is radiation oncology, and how do we use radiation to lower the risk of breast cancer recurrence? And some of the time, how do we use radiation to reduce the amount of surgery that needs to be performed?
So radiation oncology is the use of ionizing radiation therapeutically to kill cancer cells. And most of the time, that ionizing radiation is X-rays, high energy X-rays. Although in some cases, there are also radioisotopes that can be used, which can be alpha, beta, or gamma emitters. But for breast cancer, most of the time, it's external beam radiation, which is high energy X-rays that are delivered to the breast in hope of killing cancer cells while sparing selectively the surrounding normal tissue. And one way to do that is to break up the radiation into small daily fractions. And this concept of what's called fractionation allows, first of all, normal tissue to recuperate in a way that cancer cells sometimes cannot, because they don't have the repair mechanisms intact, and radiation is more successful at killing them by inducing DNA damage in the cancer cells that they cannot repair. This fractionated radiation regimen can be anything from a few treatments, like 5 to 6 or 7 weeks of radiation 5 days a week, depending on the clinical scenario. For treatment of breast cancer, radiation is used in several settings. Most commonly after lumpectomy as part of breast conservation therapy, where it basically takes place of the completion mastectomy, and the goal is to clear the remaining mammary tissue of any microscopic disease that may be left behind. And we know that it improves the chances of not having the cancer come back by anywhere between 50 and 70%. So it's pretty effective. Also, for women who have gotten a mastectomy, if there are certain features like the cancer has traveled to the lymph nodes, or the initial tumor was very big or invading the chest wall or the skin, or there was what's called a positive surgical margin, meaning that there was still some cancer cells left behind at the edge of where the surgeon cut, the radiation can help kill those remaining cancer cells. And in certain cases of highly aggressive inflammatory breast cancers, etc., the radiation becomes very important, because even with a mastectomy, it may not be sufficient to remove all the cancer cells. Sometimes these patients get preoperative chemotherapy, which I know Dr. Cohen's going to talk about next. But in rare cases, when that's not enough to shrink the cancer to where it can be resected, radiation can be used before surgery. This is an uncommon case scenario, but it's in some cases it's very effective. And then also, in the unfortunate cases where the cancer is spread outside the breast and the regional lymph nodes, this is now stage 4 systemic disease, radiation can still play a role at mitigating some of the pain at the metastatic sites, or some of neurologic deficits, and so forth. It can control bleeding in tumors that have invaded the skin. And the side effects of radiation really depends on what it is that we're irradiating. For breast cancer, when we're treating the breast, the main side effects that a patient can expect is some fatigue. It's the one generalized effect of radiation on the body, and also a skin reaction, which we commonly describe as being akin to a sunburn. It's gradual. So over the course of those 3 weeks or 4 weeks or 6 weeks, there will be a gradual reddening of the skin. It might look like the patient is breaking out in a rash. It might become itchy. And in certain cases, it might blister, like during a bad sunburn. And there's a whole host of skincare products that we recommend to minimize that. And we can also assure the patients that this, just like a sunburn, will go away, and it always does.
So we have a couple more comments here, as sort of turning to systemic therapies. Amy writes, what can we look forward to in the treatment of breast cancer? What's new? What's promising? Stephanie writes, can you explain the term complete response, or what we call pathologic complete response, or PCR, after chemotherapy? Does that mean that all cancer cells are destroyed? And what is the rate of recurrence in women who have had a total response to preoperative chemotherapy? So I think we'll start with Stephanie's question first. Basically, you know, in patients who are given neoadjuvant or preoperative chemotherapy, you know, we can actually see the tumor shrinking in front of us. So we have sort of a readout of whether or not the chemotherapy is working. When we do surgery first and chemotherapy second, then we really don't know how well the chemotherapy works. We just know, statistically speaking, that if you treat 100 patients with chemo versus 100 patients without chemo, that if they meet certain criteria, the chemo patients will do better. Of course, not all patients need chemotherapy. And again, another discussion in terms of how we decide who needs chemo and who doesn't need chemo. So there are certain subtypes of breast cancer that are more responsive to chemotherapy, and in particular, the estrogen receptor negative breast cancers and the HER2 positive breast cancers. And so if you have either of those types of breast cancer, we often, although not always, will recommend chemotherapy first and surgery second. And then if you have a pathologic complete response or a PCR, then your overall long-term prognosis is very good and your risk of recurrence is quite low. Now, not every person who's treated with preoperative chemotherapy will have a pathologic complete response, and it's not a disaster if there is residual disease. We can sometimes bump up the postoperative therapy in order to compensate for the fact that there is residual disease, or there are certain subtypes of breast cancer, in particular the estrogen receptor positive breast cancers, that are not necessarily expected to get a pathologic complete response. So we're not necessarily disappointed if that happens and there is residual disease for estrogen receptor positive breast cancer. In terms of how do we determine what is a complete response, that's a little bit technical, but generally speaking, we say that there is no residual invasive cancer in the breast or in the local regional lymph nodes, generally in the axilla or the armpit. There's some debate about exactly what the perfect definition is, whether or not you can have in situ cancer, but that's getting into the weeds a little bit. As far as what's new for breast cancer, well, it's endless. I mean, drugs are approved all the time. We have new classes of drugs. We have new drugs within the same classes. So it's really, there's a lot of great medicines on the horizon. So I'll just cover a few of them so far. We're very excited about what are called antibody drug conjugates. And the antibody is a molecule that is harnessed from your own immune system, and that is attached to a chemotherapy molecule. And so it allows you to target a cancer cell very specifically and deliver chemotherapy directly to that cancer cell while minimizing the systemic dose of chemotherapy and the damage to healthy tissues elsewhere in the body. And there are several drugs along these lines, and trade names. I'm not sure if we're allowed to use the trade names, but there's one called sacituzumab govitecan, and that's used in triple negative disease. There's another one that is called, the names get more and more complicated. It's called Enhertu is the trade name, and that's used in HER2 positive breast cancer. And then very excitingly, we have a recent important study that shows that that Enhertu works in what's considered HER2 low breast cancer, which is a sort of paradigm shaking finding. We have oral drugs that can help treat breast cancer or reduce the risk of breast cancer recurrence. We have what are called CDK4/6 inhibitors, and they are really revolutionary in their ability to treat metastatic breast cancer and now to prevent recurrence from early stage breast cancer. We have what are called PARP inhibitors, which have particular utility in patients who have germline or familial BRCA1 or BRCA2 mutations. And then we have immune therapy that is useful in patients who express a high level of something called PDL1 or who have what's called a high tumor mutation burden in their tumor. So again, there are many new classes of drugs. We have a whole bunch that are coming down the pike that are not FDA approved yet. We have the oral SERDs, selective estrogen receptor degraders, that are thought to be particularly useful in patients who have acquired resistance to anti-estrogen medications. So, lots going on. And, I'm happy to answer any other questions that might come up. We'll just take this question, then sort of goes back to our initial section. Anonymous says, if someone has a positive biopsy, how do they know what doctor to see first? And I guess we'll refer you back to Dr. Kapenhas for this.
So generally, when a patient has a positive biopsy, either they get referred to the breast surgeon by the radiologist or by the primary physician or by the gynecologist. So it all depends what kind of arrangement has been made, whether, their physicians want the radiologist to refer them to a breast surgeon or whether they want to refer the patient to a breast surgeon themselves. So that would be the initial step.
Dr. Stessin, can you elaborate a little bit about our multidisciplinary approach to breast cancer at Stony Brook?
Sure. So that's a great topic, and I think it's very important to recognize that breast cancer treatment is a multidisciplinary field, and it requires the joint effort and collaboration from a whole team of medical practitioners, including diagnostic radiologists, pathologists, the breast surgeons like Dr. Kapenhas, plastic surgeons, medical oncologists like Dr. Cohen, and radiation oncologists like myself. Also, we rely on the support and help from our nurse navigators, our nurse coordinators, our surgical nurse practitioner like Desiree Fetcher, our oncology PA, Lawrence, our survivorship nurse practitioner, Claire Moran. And for radiation oncology, it's very much a team effort because we also have a whole team of medical physicists and dosimetrists who help us design the best possible plans. We also have the radiation therapists who set up the patient on the table daily and who are extremely important in the radiation treatment. And then we also have the oncology certified infusion nurses, the chemopharmacists. So it really takes a village. And we all come together in weekly meetings. This is where we really work as a team. We have what's called a tumor board. So these are meetings that we have every week, usually on Friday mornings, where we discuss some of the more challenging cases and rely on these meetings to have the group weigh in, have a meaningful discussion, and try to figure out the best course of care and get a consensus from the group. And we also have our clinical trials team. Clinical trials are hugely important for improving efficacy or reducing toxicity of treatment. And at Stony Brook, we pride ourselves on having a lot of clinical trials that are open to our patients with breast cancer. Dr. Kapenhas, Dr. Cohen can talk about some of the trials in their respective disciplines. I can tell you that with radiation oncology, we have several trials in place that are trying to further figure out, who are the patients in whom we should be doing a little bit more, and who are the patients in whom we can do less. For patients with stage 1 breast cancer that's estrogen driven, that doesn't really have any high risk features, can we do breast conservation without radiation in some cases? Or in some cases where the cancer has traveled to a lymph node, and yet this is a genetically indolent cancer that has a low risk for recurrence based on the oncotype genetic assay. Can we spare them nodal radiation and just treat the breast? So these are some of the questions that are being asked in our clinical trials, and we're happy to offer these to our patients. And so far we've had an easy time accruing to these trials, and patients are really appreciative of it because this really represents the cutting edge in our field.
So as a medical oncologist, which is someone who specializes in so-called systemic therapies, clinical trials are very important, both in terms of how we choose established therapies and also how we develop the field and how we improve our cure rates and reduce our side effects from systemic therapies. And, like Dr. Stessin said, we have a very robust clinical trials office with research coordinators, research nurses, and so on, in order to accommodate all the regulatory issues with clinical trials, and also to keep in touch with our patients and make sure that everyone is doing well and any issues are addressed immediately, and people feel very connected to what's going on. In terms of types of clinical trials, we have several different general types. There's one we collaborate with pharmaceutical companies. So a pharmaceutical company will be testing a new drug, and that drug will evolve through preclinical trials, studies in cell lines in the lab, and then studies in animals, and then eventually studies in humans. And they say it takes about $1 billion to bring a new drug to market. So it's a considerable investment on the part of the pharmaceutical companies, and it involves thousands of patients participating all around the world in order to demonstrate that a new drug is useful, is better than an old drug or an old combination of drugs, and is worthwhile to be FDA approved and given to patients in oncology offices all over the country and really all over the world. So we also have what are called cooperative group trials, and cooperative groups are large consortia of academic institutions, again, that exist all over the country, and it allows us to run very large clinical trials with hundreds or sometimes thousands of patients participating in order to really test whether or not a new drug is better, say, than the old standard of care. And they help running a trial at multiple sites, at hundreds of sites around the country, helps eliminate bias, because each institution will contribute a few patients to the trial. In aggregate, it'll be hundreds or thousands of patients who participate, but the data is analyzed in a very objective way to minimize bias and to really find out, again, whether a new drug or a new combination of drugs is better than the previous standard of care. And then finally, we have what are called investigator-initiated trials. These tend to be smaller trials. They take place at a single institution frequently, and these could be anything from treatment trials to observational trials to trials in quality of life issues. We've done some quality of life trials here, measuring fatigue in breast cancer patients getting chemotherapy. We've done some biomedical imaging trials. We've used MRI or fMRI, functional MRI, and PET scans to look at how the brain changes in the presence of chemotherapy and what might be the the underpinnings of the phenomenon of chemo brain or chemo fog that some people complain of. We have trials of breast density, new drugs, or repurposing old drugs to try to modulate breast density to protect women from developing breast cancer, as breast density is a risk factor for breast cancer, and also making mammograms more sensitive by reducing the density of the breasts that the mammograms are looking at. And then we work on developing new types of imaging for breast cancer, new types of cameras to look at the breast that measure PET scan signal or MRI signal, or that measure new targets. So instead of only looking for, the metabolism of a tumor, we can look for, whether or not a tumor makes its own estrogen and so on. So again, clinical trials are very exciting. And as a large academic institution, we are involved in a whole slew of different kinds of clinical trials. And as far as clinical trial participation, we highly recommend it to all our patients, that although technically a clinical trial, benefits the next generation of patients, right? Because if you're on a randomized trial, you don't know if you're going to be on the better arm. We don't know if the experimental drug is better than the control drug, or the control drug is better than the experimental drug. But there are studies that show that people on clinical trials actually do better in the long run, just by virtue of the fact that they're being watched very carefully. They're very connected to the cancer center that they're being treated in. And again, we highly recommend participation in clinical trials. In terms of, other things that we were considering talking about today, we wanted to talk just a little bit about the emotional aspects of breast cancer. And I wonder if Dr. Kapenhas, you could start to cover that for us.
So the breast cancer diagnosis doesn't just change the life of the patient who was just diagnosed, but it actually changes the life of their whole family. My advice to them is, the diagnosis of breast cancer can be shocking, in fact, it can be paralyzing to some patients. What I tell them is that each patient is unique, and their treatment is tailored towards them. So the experiences that their loved ones, their family members, their friends have had during their breast cancer journey may not necessarily be similar to the experience that this patient is going to have. I also tell them that they should take things one step at a time, look at things one step at a time, one treatment at a time, one day at a time. Otherwise, it can become very overwhelming. And you also got to be careful who you speak to and where you get your information from, to make sure that the information you're getting is actually accurate.
Just a couple more questions from the viewership. Linda asks, do we have any preventive clinical trials for breast cancer that the community could participate in? And, I'll just answer that myself. I think the most relevant trials are the trials of breast density. Again, something like 40 to 50% of women are considered to have dense breasts on mammogram. Again, it's a mammographic finding. It's not really a description of what the breasts feel like and so on. And although breast density seems to be particularly increased in younger women, you can see it in women of all ages, whether women are premenopausal or postmenopausal, whether they're in their 70s or 80s. We've seen women with very dense breasts. And again, dense breasts are an issue because, one, it makes the mammograms harder to interpret. They say it's like looking at a snowflake in a snowstorm, and you really can't see much in that context. And also, the denser the breasts, the higher the risk for breast cancer. There's a famous article in the New England Journal that shows breast density. And if you compare the women with the densest breasts to the women with the least dense breasts, the quote unquote fattiest breasts, the risk of breast cancer is approximately 6 or 7 times higher. And that's, that kind of differential in risk is essentially a similar risk to a BRCA mutation. So again, breast density is a very important risk factor. So the 2 trials that are investigator initiated by Dr. Stopek, who's the head of our breast cancer division in medical oncology, the trials have to do with using an anti-inflammatory drug in the same class as ibuprofen or naproxen, and randomizing patients to the drug versus placebo to see if the breast density decreases. And we're able to measure the breast density with a very sensitive technique that's more sensitive than the traditional mammogram, which is a quote unquote fat/water MRI. And it's a short MRI protocol without contrast. So it's completely safe. There's no radiation exposure. There's no contrast exposure. And again, hopefully this will lead to new standards of care in terms of breast cancer prevention. Also for women who are high risk for breast cancer, whether it's because of their genetic background, because they're known to have a BRCA mutation, or just because they have dense breast, or they score very high on some of our breast cancer algorithms, there are things you can do. Obviously, well, one thing, we can increase the intensity of screening. Sometimes what we'll do, especially with women with dense breasts, is we'll alternate mammograms with tomosynthesis, which is the 3D mammogram, alternate that with MRIs at 6-month intervals. And that way, you're getting a test every 6 months. And if anything appears, we'll generally catch it quite early when it's easiest to treat and to cure. And also, it's actually FDA approved to take certain anti-estrogen drugs as primary prevention, meaning patients who have never had breast cancer, but who are just considered high risk for breast cancer, they could qualify for treatment with drugs like tamoxifen or raloxifene or other anti-estrogen drugs in order to reduce the risk of breast cancer. And that's never been that popular because, many people, feel suspicious about taking a drug, for a problem that they don't yet have. And of course, there's a huge stigma associated with anti-estrogen drugs. What we can assure you that you do not grow a beard on an anti-estrogen drug. And although they can have side effects, they're often well tolerated. And there are multiple drugs that we have available to us. So if you don't tolerate one drug, we can try another drug and so on. And worst comes to worst, it's not like a speeding train that you can't get off of. If you try an anti-estrogen drug to try to reduce your risk of developing breast cancer because of your high risk features, whether it's dense breasts or something else, you can always stop it. It's easy enough to start and even easier to stop. There's another question here, which is how do we treat lymphedema? Dr. Kapenhas, do you want to chime in about lymphedema a little how much do we see it, and what can we do about it?
So there are different degrees, obviously, of lymphedema. The key in setting up lymphedema is to catch it early. At that time, you can send the patient for lymphatic drainage, and potentially it can be reversible. But if it's not picked up and it's pretty advanced, then it may not be reversible. So the key would be if even there is minimal amount of lymphedema, and that can be actually picked up in patients who are high risk for lymphedema. For example, if someone had axillary node dissection, they can be seen by a lymphedema specialist. They can do arm measurements, and if there is any discrepancy between the measurements between the two arms, the right and left arm, and the side of where they had the axillary node dissection, there is the measurement is more because of even minimal lymphedema, then they can go through the treatment of lymphatic drainage, and potentially even wear compression, they're like compression sleeves that they're measured for, and they can wear it, and that can also keep it under control, so that it doesn't progress and potentially even reverse it.
Right.
Dr. Stessin,
Yeah.
did you want to say something about lymphedema?
Yeah, no. So I was going to add to that. So the question is, who is at the highest risk of getting lymphedema, right? And it's the patient who has gotten a full axillary dissection, and then on top of that, will get nodal radiation, and the risk there is can be fairly high, as high as 35 to 40%. And so one question is, can we do less, right? Can we pull back from doing a full axillary dissection if we know that the patient is going to be getting nodal radiation afterwards anyway? And some of the recent trials tell us that we can with impunity, and so doing a little bit less to minimize the risk of lymphedema is important. But then sometimes you can't do that, and as Dr. Kapenhas was saying, it's all about acting on it early. It's that's what I tell my patients. It's a use it or lose it principle, right? So as long as the patient is sort of proactive and starts exercising early in the postoperative period, not exorbitant exercise, but kind of gently but constantly increasing the range of motion and so forth, that usually leads to the best outcomes.
I'm sorry, I just want to add a brief thing. In cases which lymphedema is very advanced, there are some surgeons who do microvascular anastomosis, to promote the lymphatic drainage of the arm. The success of it, I guess, depends on who does it, how much experience they have, and it's not, although it's done in certain places, it's it's not done everywhere, and the success of it is it's kind of I would say a wide range of success. So that's another thing, but those are in advanced cases.
Yeah, and I mean, the best way to deal with lymphedema is not to induce it in the first place. So, we've gotten away from taking a lot of lymph nodes out of the armpit. When I first came to Stony Brook about 12 years ago, it was much more common practice. And unfortunately, some of the patients, who I started taking care of in that era, some of them do have large swollen arms that, are uncomfortable and cause them problems, both in terms of using their arms and in terms of cosmetics. But as the field has evolved, the surgeons have new data that allow them to avoid taking more lymph nodes out of the armpit. So now typically we take no more than 2, 3, 4 lymph nodes at a time, using the technology of the so-called Sentinel lymph node biopsy and identifying whether or not there's cancer in the first few lymph nodes. And then if there's, historically, if there was no cancer in the first few lymph nodes, we didn't take out the rest of the lymph nodes, and that significantly reduced the risk of lymphedema. lymphedema. And now there's information that suggests that even if we do find cancer in the first 1, 2, 3 lymph nodes, that you don't have to go ahead and take out the rest of the lymph nodes, that even if there is any residual cancer under the arm, we can usually take care of that with a combination of systemic therapies, chemotherapy, hormonal therapy, and so on, and radiation. So again, so we're taking out many fewer lymph nodes than we used to. Plus, we're using the neoadjuvant or preoperative chemotherapy to shrink disease, to eradicate disease, both in the breast and in the lymph nodes under the arm. And that also further allows us to minimize the amount of lymph nodes that have to be taken out and ultimately minimize the risk of lymphedema. So I think that is about all the time that we have. I wanted to thank Dr. Stessin and Dr. Kapenhas for participating and answering all of these questions and with such thorough and interesting answers. We'd like to thank the rest of our multidisciplinary team. And like Dr. Stessin told us earlier, this involves a lot of people, both doctors and nurses and all sorts of skilled and experienced people. The pathologists, diagnostic radiologists who read the mammograms and the MRIs and the ultrasounds, the breast surgeons like Dr. Kapenhas, the radiation oncologists like Dr. Stessin, medical oncologists like myself, Dr. Stopek, and our third breast oncologist, Dr. Baer. Of course, there are all the chemo nurses, the radiation therapists, the clinical trials office. It goes on and on and on. As Dr. Stessin said, it does take a village to take care of women with breast cancer, and of course, a small percentage of our breast cancer patients who are men. I wanted to mention that we do have a mobile screening van, a mammogram van that I believe is funded by a grant from New York State, and it drives around the island and makes mammograms available to people who may find it difficult to come in or make an appointment for a mammogram. And the major criteria in terms of qualifying for a mammogram from our screening mammographic van or at our breast center is you should be age 40 or older, but you could be insured or uninsured. We do have an all-female staff on the mammo van, and so people should feel pretty comfortable about privacy and so on. And you do not even need a prescription for participating or for getting a mammogram in the mobile screening van. So thank you everyone for tuning in. If you want information about the mobile screening, the phone number is 833-MY-MAMMO, MYMAMMO. And for any information or appointments at our cancer center or our breast center, you can call 631-SB-CANCER, SBCANCER, or 631-722-2623. Or you can find us online at cancer.stonybrookmedicine.edu. So again, thank you, Dr. Stessin, Dr. Kapenhas. I'm Dr. Jules Cohen, and we look forward to talking to everybody again sometime. Thanks for tuning in.